Thanks, Kurt, for inviting me to speak. And I really focus today on a couple of areas. I have done a lot of research in the last 12 years. So since the time I moved to Edmonton in Alberta, and just quickly put up my disclosures. And it's also something where I invited Kurt as well as others in Australia to join us on a clinical trial, which is a challenging area, which is about chest compression. But I will go in all the details in the next 45 to 50 minutes. So this is where we actually start, is that we are lucky that, because most newborns don't need our help, 5 to 10%, depending on the articles you read, of newborns will need some help from a respiratory perspective, which remains the most critical step. But then there are these occasions, and they're not often in term, they're more often in preterm babies, which require chest compression or medication at birth. And depending on the papers, again, it could be up to 2 to 3 million of babies a year. And despite our best efforts, many of them still don't make it, and they pass away. Now, when we provide chest compression, we also know that many of them have a high incidence of mortality. And again, depending on the articles, it can be 40%, it can be also 60%, and also short-term neurological morbidities, HIE, seizures, but also survivors, if they have more than 10 minutes of CPR, there's even higher rate of mortality, and as well as more moderate to severe disability. So overall, when you look at chest compression, we have poor prognosis when they happen, and it always raises the question as whether are there any improved techniques available which are specifically tailored to the newborn that could improve outcomes. Our problem is that we certainly never can predict when chest compressions or CPR will happen. It's really infrequently used. In our hospitals, maybe 5 to 10 times a year, and we are a high-risk delivery center. And that certainly has limited our ability to perform rigorous clinical studies to determine what is actually the best method to deliver chest compression to newborn infants. Now, these are our current approach. If you look at the international consensus of cardio resuscitation and science and treatment recommendation, you can see that whenever the heart rate is less than 60, despite you provided adequate ventilation, you should start chest compression. You should use the 3-to-1 compression to ventilation ratio, which is 90 compressions and 30 inflations, so that you get the total of 120 events. You should use the 2-thumb encircling hand technique, which is preferred over the 2-finger technique, because animal as well as simulation studies have shown that you have improved cardiac output and improved performance and less fatigue. And you can perform them from the side or from above the head. That's what the guidelines say. And you should use 1/3 depth of the anterior posterior diameter, even though we have no way of getting any feedback if we're doing 1/3 or more or less. And you need 100% oxygen. And I will go through all of this throughout my talk. Now, the first is what we need to assess is the heart rate actually less than 60? And our techniques of assessing it's rather crude. In most cases, we can palpate, but we know that's inaccurate because we might be stressed and might feel a pulse even though there's none there, or the pulse is already quite weak and we can't feel it as accurate. Auscultation is another approach, but also, again, it's often takes quite a while because no one does that 6 seconds. The guidelines tell you to just listen and then multiply it by 10. It's often loud, so it's also hard then to hear the heartbeat. Both are intermittent because you just can do it to a certain time and then you have to move on. And then certainly we have moved on to other modalities like pulse oximetry. For pulse oximetry, when you have to put it on a baby, it can take 90 seconds until you get a signal. And if there's low cardiac output or even a systole, it might not work at all. So it's quite challenging to get a reading sometimes. ECG is currently the fastest if you read the guidelines, but you have to be aware that there could be pulseless electric activity. And there have been case reports published where, a case series as well, where people saw pulse, there's electric activity, and then they didn't start CPR because they saw a pulse. Or maybe saw a pulse of 70 or 80 and just provided positive pressure ventilation. And that certainly was not the idea about the ECG, but we were always told we only have a systole, and only in the last few years, this complex of there could be pulseless electric activity as well is coming more into the forefront. So we need to be aware of it. Ultrasound might be a nice alternative, either Doppler ultrasound or just a quick POCUS ultrasound to see actually if the heart is beating or not is beating. So that might be an interesting or quick feedback device to be used to do an initial assessment to see if the heart is actually having any cardiac output. Now let's look at many of these factors which influences the efficacy of our chest compression. And there's a lot of studies over the last few years which have brought a little bit more information of what actually is the correct things to do. Now let's look at rate. We all have been told that heart rate in a newborn is 120 to 160. When we do CPR, we reduce that heart rate to 90 per minute because we need to give enough time to get at least 30 breaths or inflations in so that we get to 120 events a minute. What that actually means is that you provide the chest compression at a speed of 120, but you only do 90 a minute because you break for the 30 inflations. The optimal rate of chest compression is unclear. Now, simulation studies certainly showed the higher your rate is, the more fatigue you get. Understandable, because if you push at 90 a minute versus 140 or 160 a minute, you will get faster fatigue. Now, a mathematical model, which really just looked at what's the best cardiac output based on the weight and rate, said, well, if you're a 3-kilo baby, 184 might be the best rate. But it's certainly something we cannot do manually in any newborn because we would be fatiguing too fast. Now, we looked into that in a little bit more detail. We used our Piglet model, and we designed what you can see here on the mannequin, a chest compression machine. It's a machine which provides chest compression for piglets in our lab. You can run a rate from 60 to 200. You can change the depth as much as you want, the speed of recoil, how fast the plunger goes down. So you can adjust a lot of these factors. And if you look at that, what you can see exactly what the mathematical model has shown. If you look at figure C, you can see that the cardiac output is increasing, and then when you go from a rate from 120 to 150, significantly increasing with increasing rate. And that's exactly what the mathematical model showed, that the faster you push, the higher your output is. But if you look at other things like stroke volume and diastolic volume in A, if you look at DP, DT min and max, which are just left ventricular functions, and they're all measured with a Miller catheter placed into the left ventricle, you can see that it's actually all plateauing off at 150. So maybe 150 gives you the optimal amount of cardiac output. Again, still hard to achieve, but maybe 150 is better than a lower rate, because that would be even more in the range of what a baby has, a newborn baby has at birth. Have we studied it? No, we haven't studied, we haven't compared the 90 versus 150, but we've done a couple of other ones. We've compared the 180 and we have compared the 60, so the both extreme ends. So we did lower and we did faster. And what you can see is that neither of that makes much difference in the time of chest compression. So it seems that even though the 90 was the one which needed always longer, it seems that maybe we need to focus less on getting it exactly right, the 90. Maybe we need to really focus more on providing adequate chest compression by pushing down and ventilation. I will have several slides about ventilation a bit later on, just to highlight how important the ventilations are, because they have been ignored for many years, not only in newborn CPR, also in pediatric and in adult CPR. And there's a reckoning that it's not only pushing hard, it's also the ventilation, which is extremely important to actually achieve ROS. Let's look at that. again, we have no way of measuring how deep we should pressure. We have no feedback devices like pediatrics or adults has, so we're just eyeballing it when we do CPR. We know from using CT scans or MRIs that if you do 1/3, that seems to be have the highest EF. And again, this was a mathematical calculation based on the MRI and CT images. You shouldn't do more than 50%. Our main problem, as I said, is that we don't know how deep we should press. If it's too shallow, it's inadequate. If it's too much, you might get more injury. Again, with our machine, we looked into that. And we actually looked at like 12.5%, 25%, 33%, so the 1/3, 40%, and we also did 50%. 50%, they all died because there were it was too much depth, so they were just sometimes rupturing the aorta, sometimes rupturing the heart. So we just did 2 or 3 because we tested it, and then we abandoned that because it was just too much. So certainly 50% is bad. 12.5% is not enough. You don't get any cardiac output. So it's also something which we tried in 4 and then abandoned because it didn't work. But if you look at the other ones, it's not much difference in the time to ROSC, and there is not much difference in carotid blood flow, in particular when you do 33 or 40%. 25% seems a bit lower. But again, there's not much difference. So again, it's maybe not that we have to focus too much on getting to the 1/3. It's more about that you need to hit a certain threshold. How we can measure that threshold is still something which we don't know, but it might be better to understand that we just have to get a certain threshold to measure cardiac output. And once we can measure cardiac output, we can maybe by ultrasound, we can figure out somehow a Doppler. When we can place a Doppler, we can feel the blood flow, then we have enough cardiac output, and this step should be adequate. What's with the correct technique? Well, if you go through the literature, and this is just 8 of them, there's, I think, 12 or 13 different techniques, and almost every 6 months or so, someone else publishes a new technique of how they hold the hands or the fingers on the chest. And most of them have only been studied in mannequins. If you look at A, this is from the side or below, what the NRP textbook in North America, and I think the Australian Resuscitation Council as well, mentions. B would be the 2 fingers, and C is then if you come from above the head. Again, we tried to study that in the piglet model, because the piglet chest is quite similar to human chest, so you can easily study that. And we just studied those 4. So we tried the 2 different 2 thumbs approaches, the 2 finger approaches, and this knocking finger technique. And what you can see is that the 2 thumbs seems to be superior in our model. Also was superior in any mannequin study compared to the 2 thumbs technique. So there certainly seems that with either approach, it might be much better to use the 2 thumbs technique and don't use the 2 finger techniques. So that's certainly something to keep in mind. When you do CPR, try to use the 2 thumbs technique. Now, let's talk about the most important thing, which the guidelines always tell us, that we have to balance the chest compression with ventilation. We need to synchronize it so that there is enough time to get the oxygen in. Why is it important? Well, bradycardia or asphyxia is bradycardia or cardiac arrest is mostly caused by hypoxia and hypercarbia. So ventilation will help more compared to an adult, where a heart attack is the most common reason why there is a cardiac arrest. What is the optimal approach? No one knows. 3-to-1 is what the guidelines tell us, but this is just something which a bunch of people in the room came up 30 or so years ago when the NLP textbook started and the guidelines started, but no one actually has really studied that in detail. Why is that important? And let's talk a little bit about what happens when you squeeze the chest, because this is something which often has been overlooked. And this is a really nice study from anesthesiology where they used a gentle push with a force of 160 gram per kilo patient weight. So if you have a 3-kilo patient, that's 520 grams, where they're pushed on the chest. But that's not really much when you think about when you push down on doing chest compression, you push with much more force, 3-4 kilos per kilo often. So you push much harder. So they did really just a gentle push. When they did that gentle push, they measured what's happening, and they measured that air comes out of the lung when they push down, and air gets drawn back into the lung when they release the chest. And this is then what they did, and they did that prior surgery for many different reasons, from newborn basically, or a few weeks old, all the way to almost 18. And they tried it in 2 different ways with the mask, and then protected after they got anesthetized and intubated. And I will just zoom in into the newborn areas, and what you can see here is that the black line is your dead space. So even with this gentle push, sometimes you push more air out than the dead space. So if you now translate that into your newborn in the delivery room, you might de-recruit the lung while you were doing CPR, because you just give an inflation every now and then, and that might be just a few milliliters, and then you push 4 mils out potentially per kilo with each of your 3 chest compression. So you get a negative tidal volume delivery to the baby. Is that true? Doing CPR, this is from a mannequin study we did many years ago, and you actually can see that. And the only place you have to look is on the blue waveforms in the bottom. You can see the blue waveforms going up, which indicates the tidal volume going in, and then you can see 2 like concave waves, and then a straight line where the flow sensor resets. And it's basically, one is your expiration, and the other one is a further expiration, which is forced by the first chest compression, because they are coinciding. If you can see that on the red line, if you just make a line straight down, where you can see that the chest compression started and there's more air exhaled. So even in a mannequin, you could see this, that there is air expelled during chest compression. When we looked in the study I showed you before with the different compression depth, you can see that higher the depth is, the more volume comes out. And that certainly is concerning. The more you press, the more volume it comes out, and the more you would need to figure out a way of recruiting the lung. And that's certainly something where we haven't really placed too much emphasis on over the last little while. Now, the force here is a bit lower than I mentioned before, and that's just because it was our machine, which doesn't need as much force and compared to when we would provide chest compression. Now, just to show you what really happens, we have that from a piglet model. We don't have that in that detail yet in humans, but we're working on it. But here you can see your classic 3-to-1, where you do 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe. And measuring this in our piglet model, and we published it several years ago. And if you just look at one of this 1 and 2 and 3 cycle, you can lose up to 4.5 mils of tidal volume with each of this cycle. So if you do a long period of chest compression, you might end up with less and less lung volume. And this may be the reason you can't get the baby back. You can't achieve ROSC because you can't oxygenate, because you lose volume every time you squeeze the chest and you don't recruit the lung. And that's maybe a reason why, in particular, all the animal studies who investigated many different things like 2-to-1, 3-to-1, 4-to-1, 9-to-3, 15-to-2 were unsuccessful, because they might have not been able to recruit the lung. Similar, when you would go to older kids, when you use what is called CCAV, and that's continuous chest compression with asynchronized ventilation. And this is normally done at PALS, where they place an airway and then they do continuous chest compression. and every 2 or 3 seconds they provide an inflation. And that looks then like this, where you just do chest compression continuously, and every few seconds you give an inflation. Again, with this approach, you also get a loss of target volume, and that's even more because you're just providing more chest compressions, and often you use a self-inflating bag, which might even has no PEEP, and it might be even worse from protecting the airway or the lungs a bit from de-recruiting, so your loss is even higher, could be up to 6 mils. And again, there's a couple of studies who investigated that and also found no difference in any of the outcome. And again, maybe that's the reason, because we were de-recruiting the lung. A different approach to try to recruit the lung comes from Vali and Satyan's group out of UC Davis, where they use a high-frequency percussive ventilation approach, and they tried to see if I provide a similar approach to the high frequency, does this help to reduce with time to ROSC, or does that improve any physiological parameters? Now, they weren't really better in time to ROSC or in ROSC success, but they certainly were able to have better PaCO2 or lower PaCO2 and better cerebral oxygenation. But this is only something done in the lamb model and hasn't been translated or ever tried in any newborn infants. We went a different way. We tried something else, and back in 2020, when we submitted the paper, we called it sustained inflation, and this is something which is also recognized in the 2015 as well as in the 2020 guidelines, that this might be an approach which needs further investigation. How did we come to that? And we were really just playing around with a mannequin, and we were practicing chest compression because we were trying something for a study, and then we were just occluding the T-piece while we were providing chest compression. And you can see that with every time we did that on the mannequin, we were ventilating the mannequin with each chest compression. And I was like, oh, that's interesting. And then we started to investigate it in a piglet model. And I will show you a video how easy it works in a minute. The first study we did the 3-to-1 as you would normally do, and we used a rate of 120 with that, what we called CCSI, and this is chest compression during sustained inflation. And we used a rate of 120 because you do 120 vents with 3-to-1 as well. And when you look at the time to ROSC, it was like 75 to 80% faster. Survival was significantly improved with this new technique. And how does it look? Well, in the end, 3-to-1, as you saw before. On the right, you can see that just occlude the T-piece, like you would give a sustained inflation, and then you start CPR. And you do continuous chest compression. This was from a trial where we used a rate of 90, but you just do continuous. And every 20 or 30 seconds, you just lift your finger for 1 second so that you can basically exhale, and then you close it again. And then you continue with chest compression. So you do that continuously. What's different? Well, if you look at the waveforms at the bottom, you can see, and you just look at the top one, the gas flow one. So when you squeeze the chest, as you already know, air comes out. But when you release the chest, air goes in. So you're passively ventilating with every chest compression. So you do 90 compressions, you get 90 ventilations a minute. This is then the difference to the 3-to-1. What does it do? When we go back and look at pushing at the chest and see how much gas goes in and out, you actually gain with every 1 cycle of sustained inflation. You like every time you push and release, you can gain up to 2.3 mils of volume. So over time, you gain a lot of volume. And that's one of the reasons why this technique might help you to improve your time to ROSC, and I will get to the clinical studies in a minute. The second thing why this might work is twofold, because you have, when you push on the chest doing chest compression, you either squeeze the heart directly, like a sponge between the sternum and the spine, and this is how you inject blood. But the other way also is your thoracic pump theory, because if you provide continuous chest compression, your interthoracic pressure increases with each chest compression. Now, if you add a sustained inflation, you have two mechanisms which increases your interthoracic pressure, which, as per theory, will help the blood flow. And then you get a better blood flow, and now you have two mechanisms which helps you to pump the blood through the body. Is that true? Yes. At least according to our experiments. Here you can see two waveforms. On the left top, you see pulmonary artery flow. This was open chest surgery, and then we did CPR. Then you can see also on the top the carotid artery flow. And this is a comparison of two studies where they used 3:1 with continuous compression and asynchronized ventilation, so that pulse probe. And if you just look at pulmonary artery flow and carotid artery flow, you can see there's no difference. So both do not have any difference in any of the flows. So neither of them really improved any of your flows. Now with CCSI, and here's just a comparison to 3:1, so the white one is 3:1, you can see that CCSI significantly improves your pulmonary artery blood flow, so it pushes more blood through the lungs doing CPR. And it also has improved carotid artery blood flow. So certainly then also gets you more blood to the brain. On the left, you can see the PAP, that's the pulmonary artery pressure, which was significantly improved with SI. The mean arterial pressure was higher. A lot of people are always concerned then, oh, but sustained inflation will reduce your venous return and will increase your CVP. And you can see there was no difference in the CVP between the groups. So we haven't seen a increased CVP with any of the techniques, not even with 3:1. So that certainly is not something where we often have too much concerns. It increases your interthoracic pressure, as you can see here, and that's the pressure measured with 3:1 CCSI and CCAV. And you can see that CCSI in both cases during CPR significantly increases your interthoracic pressure, which helps that the blood can flow. So these mechanisms can help to support that approach of CCSI. There's a couple of LAMB studies who tried that. One from Satyan and Vali out of UC Davis, and then one from Stuart Hooper and Graham Pogles. In both cases, there was no difference. But in sheep, you can't do the same approach of chest compression. You either do more like an abdominal compression upwards, or you push the chest from the side. So that mechanism of passive ventilation, where you squeeze the chest, air comes out, you release, the air goes in, isn't really working with either of this with the LAMB model. So that's why they didn't find any significant difference or any difference between CCSI or 3:1. Now, after many years of studying this in animal models, and in any study we did, we showed faster time to ROSC, there was less mortality, they needed less epi, improved hemodynamics, higher minute ventilation, therefore improved alveolar oxygenation, the passive ventilation I mentioned. We've never seen a pneumothorax. We did lung and brain injury markers, and we found no difference. And we knew we needed a distending pressure of at least 25 to open the lung based on stillborn piglets or neonatal deaf piglets. We went on to do randomized controlled trials in the delivery room. The first trial we did was in less than 32 weeks gestation, which was just a feasibility, and you can see the numbers on the right, extremely small, 5 with CCSI, 4 with 3:1. Again, time to ROSC was significantly reduced, again by 75 to 80%. Many of these babies were like 25, 26 weeks old, so there were some deaths. You can see 2 with CCSI and none with 3:1. So extremely sick patient population from the get-go, but also some died with CCSI. When we looked at respiratory parameters, we were able to see that minute ventilation is certainly significantly increased. The PEEP is much higher because you give a sustained inflation. which is your PIP, and then when you push the manometer, the needle moves up and down, so you get some PIP and PEEP, which is quite similar. And then we moved on to a bigger trial, to the SURVIVE trial, which was a cluster randomized controlled trial, which as primary outcome based with the DSMB, we decided to do time to ROSC defined as heart rate greater than 60 for 60 seconds, which means once you had a heart rate of, let's say, 61, that had to stay over 60 for 60 seconds before you can call time to ROSC. And we use auscultation to identify that the heart rate is correct. And this was also a null hypothesis to see if that increases or decreases the time to ROSC. Based on what we had on data, we thought, okay, we need 218 infants, 104 in each group. Every baby, preterm and term, who requires chest compression in the delivery room is eligible. And we randomized each hospital to 12 months to 3:1 or CCSI, and then after 12 months, they would swap. Good. And here's just a little map of interest across the world. None of the markers represent any city. They're just there as markers for the country. So you can't interpret it which city might have been participating or not based on that. But this was the initial. And then before we started, we did media tours so that we really, not having parents who don't like that we experiment on chest compression in the delivery room. And fortunately, and you all know that study, the SAIL trial came out. And we had to stop the study because an initial sustained inflation increased mortality. We used sustained inflation because we called it sustained inflation, because sustained inflation, when we first published it, was a hot topic. So we called it sustained inflation. So we had to actually stop the trial. And then with discussion with the steering committee and the DSMB and ethics committees, we agreed that we only do 28 weeks or older and term infants, and used the same exclusion criteria as before. And certainly because of the bad publicity of potentially SAIL and a lot of fear of SAIL, a lot of sites dropped out. Totally understandable. So then we ran into the next issue, and this is an issue you might not see with other trials. Several ethics boards that didn't want to approve the trial until they got more safety data, which is fine, but it was certainly something which is different to adult trials and might reflect a different approach or a reflection of their own fears. Or so having a child who potentially requires chest compression. And it's also challenging to get insurance companies, because you need an insurance whenever you do a clinical trial outside your own country. So it certainly was challenging to get the contract, and it took us 3 years to get them for some countries like Austria, for example. So that was really challenging. And then, as you can see, because it took so long, many sites dropped off. And then, as you all know, COVID came around, study was paused, we couldn't do any new studies. And then certainly we ended up only with 4 sites, 2 in Canada and 2 in Europe. And then we had to stop the trial because it was already ongoing for 5 years. And we were still struggling because of COVID, and then we just stopped the trial. And unfortunately, because of all these problems, we didn't get many babies. We only got 11 and 14 instead of the 104 or 109 babies in each group. Here are all the delivery room intervention. You will see there's not really much difference. In the important outcomes, you can see small numbers and really not much to interpret it. And the only p-value you need to look at is that Cox p-value of 0.16. But you can see there's quite a trend. 90 seconds for CCSI, 615 seconds, so over 10 minutes for 3:1. There's certainly a trend, but the numbers were too small to have any significance. And if you look at registries, you can see that the number of 10 minutes or so is within the time frame of what's out there, and you normally do CPR on. Survival was bigger, but it was a bit smaller, lower in the 3:1, because in an American registry, it's 64%. We only had 42%, but with CCSI, we had 82%. So certainly was a higher survival overall with CCSI. No harm, no pneumo, no IVH, one IVH with CCSI, but 2 IVHs with 3-to-1. So there certainly was also no concerns from that perspective. So in conclusion, we had no difference in time to ROSC, no difference in survival. Delivery outcomes and secondary outcomes were not different, and there was no safety concerns. Now, when you put those two trials together, you can see there's a significant reduction of almost 2 minutes of chest compression. No difference in mortality because numbers are way too small, but that's certainly something which is interesting. And because of that, we're actually preparing for Survive 2, which will try to do the same. We just applied for a grant from the Canadian Institute for Health Research, and hopefully next year in January we know if we get funded. If not, we're going to apply again, and then we will try to do the trial again. This time, given that there's much more data out, we have much more interest, and I also spoke to Court about it, and hopefully Newcastle as well as other sites in Australia will join the trial to maybe answer or provide more answers to the question, what is the optimal approach for chest compression? Briefly about oxygen, there is certainly no data out, and if anybody has ever done CPR with less than 100% oxygen because it was by accident, then please publish it, because all the studies have been done with 100% oxygen. Animal studies suggest that less might be fine, but again, none of them has anything done more than short-term investigations, and these are all the studies which are out there. If you put them into meta-analysis, you can see that there's no difference in mortality or time to ROSC. But again, it would be nice to know if there's also any long-term issues or anything. It is certainly much more challenging to do an oxygen study, because when you try to ask neonatologists if they're interested, there is much more reluctance. And if you ask, I've gotten maybe I would do 50% or 60%, but never 21%. So I think there's much more fear that doing less than 100% could be actually harmful. Before I conclude, I want to briefly talk about vasopressors, because there's a lot of things happening in the last little while. Epinephrine or adrenaline, as what we use, is actually given in the guidelines. In the treatment recommendations, they say 0.01 to 0.03. In our guidelines, they say 0.02 to make it easier that you don't have to figure out the dose. You give it every 3 minutes. You give a flush afterwards of normal saline of 3 mils. The 3 mils is because they might be going faster to the heart. And that's really only based on animal data, because human data are really, really lacking. And you can see here, this was done by Ilkor several years ago. And you can see these are all the studies out there to really look into the route, dose, and interval of epinephrine delivery. And that's really just like 137 patients, not really much. But they recommended that it is IV would be the preferred approach. More recently, and this is a nice study because, you know, the endotracheal epinephrine is somehow like a bad boy in the sense that you shouldn't give it, and if you give it, people might say, oh, really, you gave it, you didn't do IV or IO. But certainly this latest analysis from a national database shows that, hey, when you do epinephrine, you might have a good chance to get ROSC. So it's certainly something you should still, I think, still try to get an IV, UVC, IO, and give the epinephrine. But looking at this data, and that's the best data we have because no one has done a randomized trial on that, it seems that it's not as bad as we maybe saw them, maybe the older studies. There were some other issues as well, and the newer studies maybe show, hey, it is not as bad. And you can see that here as well, with the median time of ROSC is slightly longer, but certainly you have some success with doing it. The problem with the animal studies is that most piglets or lambs, when you do CPR studies, they need epinephrine to achieve ROSC. So it's really sometimes challenging to figure out much about the drug because you need it. You can't really resuscitate without needing them because they don't come back. So it's a bit challenging to do certain things in an animal model. But a lot of things are done, and just recently, just in the last few months, there was a few studies published. This is one of them where certainly when you give ETT epi, you should never do high dose. You just do the standard dose of ETT epi because the high dose might work, as you can see they achieved ROSC, but they had a lot of bleeding in the brain histology. So certainly not something which would ever recommend, but that's something that as it has been studied that high dose is actually bad. So don't give a high dose ETT, use the standard dose. You might have some success, but always try to get a vascular access to actually give it IV or IO. We have done something differently, and that's the last few slides. We looked into a different drug, vasopressin, which is not something we commonly use, but it's something we use more and more. It's an antidiuretic hormone we all have, and it has some effects which might be not bad for CPR. It can result in pulmonary vasodilatation, which is actually what you want at birth because you have vasoconstricted pulmonary blood vessels, and it causes systemic vasoconstrictions. And compared to epinephrine, it is not affected by respiratory or metabolic acidosis, and it does not increase myocardial oxygen demand. And why seems that interesting? Well, hypoxia is the most common reason that we in general get cardiac arrest and bradycardia or systole. And apparently in adult randomized trials, it shows that in a systole, you have a significant higher rate of ROSC at hospital admission and hospital discharge when you use vasopressin. Similar, it's really rarely used in pediatric patients, but when they use it, and they often used it much later as a rescue drug and used epi first, they found that more babies would get survival and even better survival to hospital discharge, even though the time to ROSC might have been similar. So there seems to be maybe a benefit of using vasopressin. And we've tried that in our piglet model. And what we found is that, all right, it doesn't really reduce the ROSC time significantly, even though it was shorter, as you can see. The survival over 4 hours was significantly improved. So certainly the pigs were more stable in the 4 hours we observed the pigs. And that's also something, it's not just the immediate resuscitation, it's the post-resuscitation, but you might have a more stable patient compared to using epinephrine. And this is just then the cardiac functions, left ventricular functions, mean arterial blood pressure, and brain oxygenation, which was improved at the 4-hour mark throughout the recovering period. So there might be something with using vasopressin that is something which could potentially become an alternative drug doing CPR. We've started last year in November to do the first clinical trial. It's again cluster. We almost completed 1 year. In the first year, we were randomized to epinephrine. So we started in November, we will finish in November, and then we have a month of teaching. And then in January, we will start vasopressin. And so far, we have 4 patients who required epinephrine in the trial. And this is just to give you an idea how rare it is to actually do epinephrine in the delivery room, in our high-risk delivery center. So will be a small first trial, but that may be something where we head on in the future. So this is just to summarize what we do at the moment. And in 2025, there will be new guidelines, and I can't tell you what the guidelines will say because I don't know. But that's certainly something to look at if there will be any differences in the guidelines in 2025. But this is what we currently do. I would like to thank all the people who over the years have been involved in any of our chest compression studies or vasopressin studies. If you want to reach out, these are all the ways how you can contact me. And now I'm happy to answer any questions.
Thanks, George. That was well, a really great overview. I was expecting nothing less from one of the epicenters of, I would say, neonatal research and research into this very difficult topic. You took us to some methodological approach to cardiac compressions, which is awesome, the little machine and the depth and how you found that out and the importance of stroke volume. Then you went to telling us what that compression does to lung volumes. And I think that was really eye-opening to see, no, it actually negatively affects lung volumes. And then you come with some solutions where cardiac compressions with sustained inflations seem to be physiologically a really nice approach. And then, I know, doom and gloom happened. Yeah, left, right, and center, which is really a pity. Well, this trial didn't happen